Hello, my name is Tom Babor, and my aim today is to provide a summary of effective alcohol public health approaches to reduce the harmful use of alcohol. And this, in a sense, is the core of the book, Alcohol, No Ordinary Commodity. We have 7 chapters devoted to different public health approaches to dealing with alcohol-related problems in a global perspective. And the chapters are based on scientific evidence for each of the policy areas that the authors have reviewed. Quickly, let's just talk about where the need for these policies come from, because that's very important. Most of the research on interventions for alcohol problems is downstream. It's devoted to prevention programs or to treatment interventions, but in effect, most of the problems connected with alcohol, including alcohol dependence, are pretty far upstream. And by upstream, we mean that people are kind of getting pushed into a river for a variety of reasons. And when we pull them out at the bottom, downstream, they're really in need of a lot of remediation. And if we could capture them upstream before they got pushed in, we'd be in a lot better shape. So the upstream sources of damage, according to the research, are low prices. Cheap alcohol precipitates more drinking and problem drinking. Easy availability. If people have, if it's convenient and they can get it easily and it's easily available, then they drink more. Also, a culture of universal drinking, which is supported by aggressive marketing. If it's expected that people drink and people are encouraged to drink socially and through the media, they drink more. Lack of regulatory controls. We have effective controls that I'll talk about, but when we have weak controls, that contributes to the upstream sources of damage. And finally, the alcohol industry strategies and tactics, including marketing, product design, and corporate political activities, contribute to the upstream sources of damage. So what are the solutions? Well, upstream, we have pricing and taxation measures, and we have a chapter devoted to that. Regulating the physical availability of alcohol, another chapter on that one. Regulating alcohol promotion and marketing is an important area, and that is, again, is an upstream source of the damage. Midstream, we have drinking and driving countermeasures, regulations and programs that are designed to modify the drinking context to get people to drink less or to shut off service if they're intoxicated. And finally, downstream, we have education strategies and treatment and early intervention. So we have chapters devoted to each one of these. And in those chapters, we reviewed over 70 strategies and interventions. And the strategies were reviewed critically by looking at the available evidence, particularly in the last 10 years since the second edition of No Ordinary Commodity. And among those practices, we looked at systematic reviews and in original research and government reports and a variety of other sources to identify best practices, good practices, and also ineffective practices. The best practices are interventions that have been found through research to be high in effectiveness in reducing alcohol consumption or alcohol-related harms, preferably at the population level. Best practices are those supported by numerous studies and systematic reviews and meta-analyses. which are capable of reaching their target audience. If you have an effective intervention like a drug to treat alcohol dependence, but it's expensive or difficult to prescribe or not available in countries with marginal healthcare systems, then it's not likely to have an impact. And finally, we look for practices that are low in cost. Good practices have some evidence of effectiveness in this literature, but not as powerful evidence as the best practices. So what did we find? Well, first, in the area of pricing and taxation policies, we evaluated 5. 4 of them were found to be effective. The most effective one was alcohol taxes that decrease affordability. These can be excise taxes or they can be sales taxes. And there's a lot of research and systematic reviews that indicate that when alcohol becomes less affordable, people drink less and they experience fewer problems. And when affordability increases, alcohol becomes cheaper, then that contributes to the level of harm in a society. Increased taxes, interestingly, reduce alcohol consumption and harm in adolescents and even in people with alcohol dependence. Enforcement is a big issue, and unrecorded alcohol consumption is another. Also found to be good practices are minimum unit pricing, differential pricing by beverage, for example, taxing spirits at a higher rate than beer or wine, and special taxes on youth-oriented beverages which discourage kids from getting their hands on alcohol products. The research is good. It shows, for example, in the state of Alaska in the USA, when they raised taxes in 1983 and 2002, there were drops in alcohol-related disease mortality. And we also have good evidence that motor vehicle crashes can be reduced when taxes are raised, primarily because people drink less and get to less harmful situations because of that. Alcohol tax policies, as indicated by research recently in Lithuania, can have effects on mortality. So when you increase the price of beer and wine, in this case by over 100%, and spirits, we found decreases in alcohol-related mortality from all the diseases that alcohol causes, and increases in the amount of revenues that are collected that can go into the public treasury. So tax policies have a benefit not only in reducing alcohol-related harm, but also in helping to generate revenues for the public treasury. So to summarize, we have a lot of evidence that governments could increase their alcohol taxes to reduce affordability, and it needs to be indexed to inflation, and the taxes based on alcohol content are better than taxation based on price. Increased tax rates are unlikely to stimulate unrecorded alcohol production and consumption if proper controls are built into the legislation. And more recently, minimum unit pricing measures have been found to be effective in several countries because they prevent the consumption of cheap alcohol beverages. The second area where we have good best practices are in the area of regulating the physical availability of alcohol. We evaluated 15 policies. 12 of them were found to be effective. They mainly consist of limiting the hours and the places of sale, often through licensing systems, public welfare-oriented state monopolies, which limit the price and the availability of alcohol, and minimum purchase age laws. So these policies have been found to be best practices. Good practices in the area of availability controls are rationing systems, restricting outlet density, especially in late night entertainment districts, and total bans, otherwise known as prohibition, where they're supported by religious or social norms. So we also found that ineffective practices are things that tend to be advocated by the alcohol industry, such as policies that increase outlet density or making alcohol more available to consumers. The more convenient alcohol is, the more people drink. An example of the reduction in harm that comes following the imposition of availability controls comes from Diadema, Brazil, where in 2002 we had a late night availability which was changed from 3 o'clock in the morning to 11 p.m. closures. And after that, there was a strong reduction in alcohol-related homicides. This in a city which had one of the highest mortality rates in not only in Brazil, but in the world. Regulating the availability of alcohol through minimum legal purchase age. The best example here is raising the alcohol purchase age from age 18 to age 21 in the United States. When that was done, there were sharp reductions in late night traffic fatalities in young people related to alcohol consumption. Monopoly systems as well in the USA, Canada, and the Nordic countries were found to be effective ways to limit availability. Restrictions on alcohol marketing is another area where we found best practices. The ones that have some support, circumstantial or empirical, in the literature are complete bans on alcohol marketing, which is a best practice, and partial bans on alcohol marketing, where there's some evidence of effectiveness, but they're not nearly as good or expected to be as good as complete bans. We know that exposure to alcohol marketing increases the attractiveness of alcohol and the likelihood of drinking by young people, and their progression to binge drinking. It also stimulates craving and potential relapse in people with alcohol dependence. So bans on marketing are recommended in part because they've been very successful with tobacco. And we now have what amounts to causal evidence that if you increase marketing, particularly in the digital media, but most of the research has been in the traditional media, we have good evidence that that leads to increases in alcohol problems in young people. Drink driving countermeasures is another success story. Low BAC levels for young drivers, intensive breath testing through random breath testing, if possible, are considered best practices. We've got a variety of good practices, including graduated licensing for young drivers, sobriety checkpoints, and administrative license suspension. What we've also found through the research is that severe punishment and designated driving programs are not particularly effective. That's because severe punishment can often be avoided by negotiation with legal authorities, and it does not deter people from drinking and driving. Other good practices are measures like server training and house policies to refuse service and enforcement of regulations in drinking establishments, education and persuasion strategies, including school-based prevention programs, have some evidence of effectiveness, and treatment and early intervention programs. But the literature suggests that it's the upstream policies that reach more people and have greater evidence of effectiveness. When you add all this together, we can point to some examples where changes of alcohol policies, particularly the imposition of alcohol taxes, the controls on availability, and bans on alcohol marketing, such as occurred in the former Soviet Union and the Russian Federation between 1980 and 2017. If you look at the data there, you can find variations in alcohol consumption, which were a function either of liberalization or the imposition of these controls. And at the same time, there's evidence that life expectancy correlates to the extent of a correlation of minus 0.91 with changes in alcohol consumption. That's powerful evidence that we can influence alcohol-related mortality and life expectancy at the population level in a country that adds up to 4 or 5 years of life expectancy in a high-consumed country. So the global landscape here is that while we have universal upstream measures that are the most effective practices, we have many other approaches targeted at high-risk groups that have something to contribute. We evaluated more than 70 of them, and the best practices and the good practices are now more numerous and more effective than ever. But for alcohol policy to use science in the public interest, there's a need for global supranational mechanisms, not just national policies, but policies that deal with cross-border marketing, trade policy, and a lot of other things that cannot be controlled at the national level. If we can put those things together, we can have a significant public health impact on alcohol-related problems. Thank you.